Bismillahirrahmanirrahim. Our lecture for today is going to be about influenza virus. The influenza virus belongs to the Orthomyxoviridae family. The Orthomyxoviridae family belongs to the RNA viruses. It's a single-stranded negative sense virus enveloped with a helical capsid. This is the electron microscopy picture of the influenza virus. As we can see, the virus has a helical capsid in here, and it has a glycoprotein within the envelope. The glycoproteins, there are two glycoproteins in the influenza virus envelope, which is the H and the N, the hemagglutinin and the neuraminidase glycoproteins, and both are of significance when we're going to talk about the antigenic drift and shift of the influenza viruses. Just a bit of a background and epidemiology about the influenza virus. Influenza viruses are divided into influenza A, B, and C. A is the most commonly seen influenza type, and as we are going to talk in a minute about the differences between influenza A, B, and C, it's the most common type of human influenza viruses. And if we look at the history, in the 1918 we had what's called the Spanish flu, which was caused by H1N1, and in that during that period more than 50 million, and some references also say that it is more than 100 million people had died by that Spanish flu infection. Also in the 1957 there was an Asian flu where 100,000 died as a result of H2N2 until we get to the 1997 where H5N1 has caused the avian flu in Hong Kong, but the cases were seen only in workers who worked with the birds, and they got rid of the birds. They buried them or they burned them in order to get rid of the virus. 2009 was the pandemic. WHO has labeled the infection with H1N1 or the swine flu as the pandemic, and the first case was seen in Mexico, and they estimated the mortality or the people who have died from that infection at 600,000. Influenza causes an acute respiratory tract infection that usually occurs in epidemics, and it occurs mostly during the winter months. During the winter we see an increase in the number of cases with influenza virus infection. These viruses receive their name from their special affinity to mucus, so they infect mostly the oropharynx, and they start replicating there. And we have three types of influenza viruses. We have type A, B, and C, and there are certain differences based on the ribonucleoprotein antigens, as we're going to see in a moment. So what are the differences between influenza A, B, and C? Influenza A, for the host range, it can infect all mammals, animals, reptiles, so it can infect humans, pigs, horses, birds, marine animals. Influenza B and C, they mostly infect humans, and C has the ability to infect pigs as well. When we talk about influenza virus infections in humans, we talk mostly about influenza A and influenza B. C causes mild infection, so we do not usually talk about influenza C. Influenza A has the ability to do antigenic shift and drift, so it has the ability for recombination and reassortment. It is very highly seen in influenza A. In influenza B, there's a chance of antigenic drift or the insertion of a point mutation while replicating the genome. In influenza C, it is mostly antigenic drift only and in a very small percentage, and influenza C is considered the most stable of the human influenza types. Clinical features: the influenza A can come as an epidemic and a pandemic, while influenza B might be associated with a mild disease, and the severity of disease increases when we go to the extremes of age, elderly or children, and it's not associated with pandemics. As I said, influenza C usually has a mild disease, and it is we usually do not talk about it. In terms of the structure, influenza virus is unique in that it has a segmented genome, and for influenza A there are 8 segments, for influenza B there are 8 segments as well, but for influenza C there are 7 segments only. In influenza A we see 10 viral proteins and one unique protein, which is the M2 protein. It's unique for influenza A. Influenza B, we have 11 viral proteins, and the NB protein is unique in the influenza B. And influenza C also has 9 proteins, and the HEF is the unique protein. The M2 protein, which is found only in influenza A, is important, and we're going to talk about it later when we talk about the antiviral drugs which are used for influenza A. And it is important because when we say amantadine, and rimantadine antiviral drugs, they usually work on influenza A only, not influenza B, and that's because it works on the M2 protein, which is present only in influenza A. Also, the severity of illness is more with type A, less with type B, and as we said, type C is usually very mild. Animal reservoir is present in A, not B and C. Human pandemics in A, not B and C. Epidemics can be seen in A and B, but not in C. Antigenic changes that occur in type A are shift and drift, in type B drift, and in type C it is stable. Segmented genome, all have segmented genome. Type A is sensitive to amantadine and rimantadine, and we talked about that earlier because it works it inhibits uncoating, and it works specifically on the M2 protein, which is present in type A influenza virus only. Zanamivir and oseltamivir, which are neuraminidase inhibitors, work both on influenza A and influenza B, and both influenza A and B have 2 glycoproteins, which are the hemagglutinin and neuraminidase, while type C only have one surface protein. The influenza virus is a spherical virus. It has a helical nucleocapsid, and it's segmented, single-stranded RNA, and it has 8 segments. Its envelope and the 2 viral encoded proteins, this one and this one, are the hemagglutinin and neuraminidase. As we said, the M2 protein is unique for influenza A. The PP protein is unique for influenza B. For influenza viruses, we have the hemagglutinin or the spikes. We have 2 types of spikes. We have the hemagglutinin or the HA or the H, and the neuraminidase or the NA or the N. And there are more than 15 or even 17 types of the hemagglutinin spike. The hemagglutinin spike, its main role is binding viral particle to susceptible cell and is the major antigen against which neutralizing antibodies are directed. It plays a major role in the binding to receptor on the target cell and playing a role in internalizing the virus into the target cell, and it is the most antigenic part of the influenza virus. The neuraminidase spike has a mushroom-shaped protrusion there are 9 types of the neuraminidase from N1 to N9. When we talk about humans, mostly the N1 and N2 are present in humans, while the other types of neuraminidase spikes are present in other animals. The NA plays a role in the fusion of the viral envelope with the host membrane, so it plays a helper role with the hemagglutinin internalization of the virus and entry into the cell, but also it plays a role in activation of the mucoprotein receptor in the respiratory secretion, and the main role, or the important role for it, is in facilitation of the release of the viral particle from the infected cell surface during budding to prevent self-aggregation of the virion. And that's important when we talk about the oseltamivir and zanamivir, which are the antiviral drugs which inhibit neuraminidase blockers. So after the virus is being assembled and is about to be released from the cell, then it requires a cleavage of the neuraminidase binding to the target cell in order to set the virus free. If we use the neuraminidase blockers, oseltamivir and zanamivir, we're going to decrease the amount of the virus which is going to be released from the cell, and thus make the virus less infectious to the nearby. This figure represents the different subtypes of hemagglutinin and neuraminidase which are present in influenza A virus. So as we're going to see in a minute, in the nomenclature of the influenza A, it includes the hemagglutinin and neuraminidase numbering. In influenza A, we can see that it has H1, H2, H3, H5, H7, and H9, while the N1 and N2 are only present in influenza A. It's worth mentioning that there are 17 types of hemagglutinin and 10 types of neuraminidase in influenza A, human influenza A species or strains. Influenza virus strain designation. So, because we have multiple types, especially of influenza A, there are multiple strains of influenza A, there should be a nomenclature design or way to name the influenza A viruses. This depends on the subtype antigen, which is this subtype A, B, or C, the host of origin. So is it a human? Is it bird? Is it swine? Is it equine? It needs to be mentioned. If it was of a human origin, then the human is not going to be mentioned, or the host is not going to be mentioned. The geographical location where the virus was first isolated, then the strain number and the year of isolation, and then the antigenic designation of the hemagglutinin and neuraminidase. And this table shows an example of naming multiple different influenza A viruses. So the description of the subtype antigen is A for this one. The host of origin is not mentioned because it's human origin. It was first isolated in Hong Kong. The strain number is 1, and it was isolated first in the year 1968. And the hemagglutinin is number 3, and neuraminidase is number 2. The second example is influenza A, which infects pigs, so it's swine. It was first isolated in New Jersey, and the strain number is 8, and the year of isolation is 1976, and it has H1 and N1. So that's how we name the influenza viruses type A. After that, we're going to touch on the replication cycle of the influenza virus. Influenza virus is a single-stranded, negative-sense RNA virus. It's unique in that it has a segmented genome, A and B has 8 segments, and influenza virus is unique also in that it's an RNA virus which replicates within the nucleus and not the cytoplasm. So we've talked previously about the replication of the single-stranded negative sense RNA viruses. Please go and revise your information about the replication strategy of influenza virus. The influenza virus genome, as we said, has 8 segments. Of most importance are segments number 4 and segments number 6, because segment number 4 encodes the hemagglutinin or the H, and segment number 6 encodes the neuraminidase or the N. And both of those represents the envelope spikes, the 2 envelope glycoproteins or spikes. Why are they the most important? Because they are the outermost part of the influenza virus. They are in direct contact with the immune system, and they are the most antigenic part of the virus. So any mutation within these 2 glycoproteins is going to lead to the previously formed immunity against the virus is going to be affected in a way. It depends on being antigenic drift or antigenic shift. If it's antigenic drift, then it's going to be minimal change in the level of immunity. So if virus X has been exposed, has infected someone, and it formed immunity for it by 90%, then if antigenic drift occurs, it's going to go down a little bit, 75, 80, 85%. But if there is an antigenic shift, then the glycoprotein most probably is going to change almost completely, and then there is no level of immunity or protection is going to be for them. So that's the significance for this. We're going to talk about antigenic drift and shift in a moment in more details. The 2 surface antigens of influenza undergo antigenic variation independent of each other, and we have 6 hemagglutinin, 1, 2, 3, 5, 7, and 9 in human influenza virus type A, and 2 neuraminidase N1 and N2 in the human influenza virus type A. So we come now to the changes or the recombination or the mutations that are being introduced into the influenza virus, which make the influenza virus one of the most variable or most has the most ability to change the shape of its spikes. So we'll come to the term antigenic drift and antigenic shift. What's antigenic drift? Antigenic drift changes within major subtypes can involve both H and N antigens. Antigenic drift definition is a single mutation in the viral RNA which leads to gradual change of antigenic properties of the strain. How does this occur? It occurs because the virus has an RNA-dependent RNA polymerase, which is encoded by the virus, and this RNA-dependent RNA polymerase lacks proofreading. So every 2,000 to 10,000 nucleotide, it's going to introduce a single point mutation. This single point mutation could occur in any of the viral segments, or any of the 8 viral segments, but it's of utmost importance when it occurs in the H and the N antigens, because they are the outermost part of the influenza virus, and any change is going to render the immunity against these, the immunity generated against these glycoproteins of less efficacy. Antigenic drift, every 3 to 5 years, there is, let's say, a slightly higher level of change which might occur. And as I usually say, let's assume that the spike has a triangular shape. In antigenic drift, what occurs is that one of the triangle angles might be lost. So there is no major change in the spike's shape. So this is going to affect the level of immunity which is generated for the first virus which has a triangle. So if the triangle or the antibodies produced against the triangle was effective in 90% against 90% of the viruses, when this antigenic drift occurs, it's going to be like 75 to 80, 85. So it's going to be less effective in neutralizing the new virus which has an antigenic drift. And usually antigenic drift, every 3 to 5 years, there is a slightly higher level of change in the spike shape every 3 to 5 years. When we come to the antigenic shift, another name for it is reassortment. It occurs when a single cell, let's assume in the lung of a pig, becomes infected with multiple strains of the virus. And when we say strains, we mean a human influenza, swine influenza or pig influenza, and avian or bird influenza. It can infect the same lung cell within the pig. Once these viruses enter into that cell, each virus is going to multiply its segments, but the problem occurs when the new virus is going to assemble. It might acquire segments from the human and the swine both together, or it might acquire from human, swine, and avian, all three together, to form a new strain of the virus which might have characteristics from human and swine, or human, avian, swine, or human and avian. And the problem with the antigenic shift is, especially if it occurs in the glycoprotein or spikes, that they are originated from either the avian or the swine. And when they infect the humans have never been exposed to this type of glycoprotein or spike. And as I usually say, if the spike for the human influenza is triangular in shape, once antigenic shift occurs, it might become circular. So there is no immunity produced, and the humans has never been exposed to such a glycoprotein structure. So the infection is going to be stronger, more potent, and it's going to affect those who are at extremes of age in a way which is going to be stronger than the immunocompetent persons. Now we're going to talk about the avian influenza A, or the H5N1. This has occurred in Hong Kong in 1997, where the humans became infected with the avian influenza or the bird influenza. And the source was domestic poultry or chickens. The virus did not appear till now to be transmissible from human to human, so that viral infection was not transmissible from human to human. It rather has infected from the birds to humans who were in direct contact with the birds. So it was easy to contain that infection and did not reach a pandemic level by killing or even burning the birds which are infected with this virus. And it was unique that they found that all the 8 RNA gene segments in this H5N1 virus were all from the avian viruses or the bird viruses, and it jumped directly from birds to humans. Also, as I said, the reassortment could occur in nature, and it occurs in the pig. Could be the reservoir for that is the pig, and it can infect a human and swine at the same time. Then a new virus with shared characteristics and proteins from the human and the pig might infect humans. And as I said, this is going to be stronger, more potent viral infection. It's going to come out as a pandemic. It's going to infect a large number of people, and it's going to infect in multiple countries, and it's going to be labeled as a pandemic. An example of that is the swine flu, which occurred in the 2009 and was labeled as a pandemic. Now let's talk about the influenza pathogenesis. So the influenza is transmitted to humans like other respiratory tract infections in the form of aerosolized of viruses which are present in the aerosols, which result from sneezing, coughing, or even talking, and especially during the winter months. So once the virus gets into the respiratory tract, either through inhalation of the aerosolization or touching and getting into contact with the aerosols on the fomites, which are infected with or which are contaminated with the virus particles, and then we touch our face or our mouth or our eyes, it's going to get there and it's going to start replication in the respiratory tract. As a result, it's going to lead to desquamation of the mucus secreting cells and ciliated cells, and they're going to lead to killing of the ciliated cells. And then influenza syndrome is going to appear, which is characterized by runny nose, mild fever, coughing, sneezing, myalgia, arthralgia, and the symptoms for the influenza are can be differentiated from other viruses which cause common cold, such as the rhinovirus and the coronavirus, in a way that the influenza virus is associated more with arthralgias, myalgias, general fatigue, and with fever. So after the influenza symptoms develop, and as a result of desquamation and loss of the ciliated cell, this might lead to secondary bacterial infection, or this might lead to the influenza virus reaching the lower respiratory tract and causing viral pneumonia. CNS and muscle involvement is not a major finding in influenza infection. So once the virus enters, then this is going to lead to activation of the immune system, activation of the B cells and T cell response. Once the B cell is activated, it's going to produce plasma cell. Plasma cell is going to produce antibodies which are specific against this influenza virus. Also, T cells are going to target intracellular viruses which infected the cells, as they are going to be targeted by the CD8, which is going to lead to killing of the virally infected cells. What are the virulence factors of the influenza virus? It has the ability to infect lower respiratory tract. It primarily infects the upper respiratory tract, but in certain cases it might go to lower respiratory tract and cause viral pneumonia. It induces pro-inflammatory cytokines and chemokines, which might lead to cytokine storm. It leads to apoptosis and death of the infected cells, especially the ciliated cells, and it might even spread systemically and go in very rarely. It can spread systematically beyond the respiratory tract, and it can evade the innate immune system and evade the interferon. This is to show the damage which might occur, especially in the ciliated cells in the trachea. And this figures show the normal trachea mucosa. Here we can see 3-day post-infection that the ciliated cells were completely lost, and it requires 6 to 8 weeks for these ciliated cells to come back to the pre-infection level. Here, 1 week after the infection and recovery from the infection, we can see that some ciliated cells started to grow once again, but the full and complete recovery requires 6 to 8 weeks. As a result of that, the patient who is infected with influenza virus, and as a result of the loss of ciliated cell, he's going to compensate for the function of the ciliated cell by coughing in order to get rid of any foreign bodies and microorganisms which are trying to get to the lower respiratory tract. Symptoms of influenza virus infection are well known to all of you, and all of you have experienced influenza virus infection for at least once during the past years. It's characterized by fever, headache, myalgia, arthralgia, coughing, rhinitis, and some patients might also have ocular symptoms, though the eye involvement is seen mostly in upper respiratory tract infections, which result from the adenovirus infection. So adenovirus might present with upper respiratory tract infection, runny nose, sneezing, coughing, and eye involvement. If we see this clinical presentation, we think of adenovirus more than we think about influenza virus. The clinical findings are seen more severe, or the clinical presentation is going to be more severe in the extremes of age, the very young, the elderly, immunocompromised, and patients who are having problems with the heart and lung disease. And influenza virus annually leads to mortality rate. So 300,000 to 700,000 die annually as a result of influenza virus infection. Most of them are elderly or immunocompromised, or those who are having pre-existing conditions in the heart and the lung. Complications, other complications as a result of influenza virus, it might lead to croup in young children. It might lead to viral pneumonia, primary pneumonia, and it might lead to secondary bacterial infection on top of the viral infection. And the number one cause of secondary bacterial infection is the strep pneumonia, which leads to pneumonia. Staph aureus and influenza also can infect secondary to viral infection. Very rare complications such as involvement of the muscles leading to myositis, or cardiac complication, or encephalopathy. Also, liver and CNS involvement might be seen in children who are treated with aspirin in the form of a Reye's syndrome. And very rarely we can see peripheral nervous system involvement in the form of Guillain-Barré syndrome. Reye's syndrome is characterized by liver fatty deposition of in the liver, brain edema, vomiting, lethargy, and coma. And it is seen in children or youth who have infection with viruses such as influenza, chickenpox, and they are treated with aspirin as an antipyretic. So please never ever prescribe aspirin as an antipyretic with viral infection. Otherwise, this might lead to Reye's syndrome in children. How to diagnose influenza virus infection? Influenza virus infection is usually diagnosed by the clinical picture and presentation of the of the patient. He comes to you complaining of sore throat, coughing, sneezing, mild fever. So these are the most common clinical presentation with influenza virus infection. And you examine the throat of the patient, and as we said previously, what you're going to see is erythema, swelling. You might see ulcers, you might see petechiae. This goes more with viral infection as a result of the pharyngitis other than the bacterial causes. So the diagnosis is mostly clinical. There are other ways of diagnosis, such as direct detection of viral antigen in the infected cells, immunofluorescence staining, isolation in cell culture, or even serological hemagglutinin, ELISA, complement fixation. Also, we can use PCR for diagnosis, but these investigations are reserved for new outbreaks of new viruses, and mostly the diagnosis of influenza is through the clinical picture. Is there a prophylactic measure to prevent influenza virus? What about treatment of influenza virus? For influenza virus, we have 4 types of antiviral drugs. We have amantadine and rimantadine, which are used as an antiviral drug for influenza A only. And we said why it is used for influenza A, because they act on they work on the uncoating step of influenza A, and specifically they work on the M2 protein, which is found and unique in influenza A only. Also, it's worth mentioning that the amantadine and rimantadine and the level of resistance for amantadine and rimantadine is very high. It's more than 90%. So it's not that effective in treating viral influenza infection. There are other types of drugs which can be used for influenza. We have the neuraminidase inhibitors, which are the zanamivir and oseltamivir. Zanamivir is given by inhalation. Oseltamivir is orally, so the only effective antiviral drug present nowadays is the oseltamivir or the Tamiflu, which was approved in 1999, and it is effective for both influenza A and B. It affects it is a neuraminidase inhibitor or blocker, and it affects the release of the newly formed virus from the host cell. And for the drugs to be mostly effective, it needs to be used very early in the disease, in the first or the second day of the illness. But in saying that, we have these antiviral drugs. What is the mode of treatment in influenza viral infection? It's not usual to use these antiviral drugs for the treatment. Treatment is usually symptomatic. So if there is fever, give antipyretic. If there is cough, we give antitussive, and we can give decongestants. We can give drugs that might treat the symptomatic picture of the patient. We might give vitamin C, might ask the patient to have warm drinks. These are the sort of usual treatment with influenza, and of course bed rest. Let's get back to the treatment with the antiviral drugs. So these antiviral drugs can be used to treat as a treatment and prophylaxis. Treatment for those who are immunocompromised, because the antiviral drug is used to complement the immune system. But if they have a weak immune system, then giving these drugs is going to help the immune system in getting rid of the virus. In certain instances, it can be used as prophylaxis. When to use those as prophylaxis? In the case of an outbreak, if there's an outbreak and the number of infections with the virus are great and the virus is more aggressive, then we can use it. In case of immunocompromised patients, in case we have in a certain house 5 households and 3 of the households has got infected, we can treat the other 2 with Tamiflu in order to prevent them from getting the influenza symptoms. But that's not the case usually, because it is a mild infection, self-limited infection, which usually goes away within 3 to 5 days. Of course, on influenza virus needs to we need to keep an eye on influenza virus and needs to be under surveillance because of the high risk of antigenic drift and shift. And as we said, in antigenic drift, every 3 to 5 years, we get a more aggressive virus. As a result of antigenic drift, antigenic shift every 10 to 15 years, maybe up to 20 years, a new reassortant virus might emerge, and this new reassortant virus is completely new. Humans has never been exposed to, and there is no immunity, zero immunity in the all populations against it. So this might lead to a pandemic, and it might lead to a higher number of fatalities. So these need to be under surveillance. In terms of prophylaxis, when we talk about prophylaxis for influenza virus, we talk about influenza virus vaccine. Do we have a vaccine for influenza virus? Yes, we do have vaccine for influenza virus. How many types of vaccine do we have? We have 2 types of vaccine. We have vaccine which is given intranasally, and we have a vaccine which is given IM. The intranasal is a live attenuated vaccine, and the IM is a killed or inactivated virus vaccine. When is the best time to give the flu shot? The best time to give a flu shot is as soon as it's ready, and usually in the US it is released as early as July or August. But to get maximum efficacy of the vaccine, it is usually best given by late September and early October in order to gain maximum benefit from it, since December, January, and February are the height of the flu season. Inactivated flu vaccine. So the inactivated flu vaccine, in the inactivated flu vaccine, we have the type A and the type B virus. Type A, we have usually the trivalent and the quadrivalent vaccine. In the trivalent vaccine, we have 3 strains of the virus, 2 type A and 1 type B of the virus, and they are all mixed together so they can be prepared. Type A virus 1, type A virus 2, and type B virus. They are grown in eggs, and then they can be harvested, pulled together, and then killed or inactivated and given in the form of a small shot, which can be given in the shoulder, in order to protect against these 3 types or these 3 strains of the virus. How do they choose these 3 strains? Usually by the end of the influenza season, recommendation, WHO recommends the 3 most virulent strains of influenza virus to be included in next year's vaccine. We have also the live attenuated influenza vaccine, which is a cold adapted virus where the virus is grown in eggs, and we start at a high degree, let's say 35, and then we start dropping the temperature of growth and incubation of the virus until it reaches 25. So this leads to the virus being less virulent, less infective, but it retains the antigenicity of the virus. So it's given intranasally. Once the live attenuated virus is given intranasally, it's going, the body is going, and the immune system is going to be exposed to the viral antigens. Also, we're talking about 2 type A and 1 type B. Then the virus is going to replicate within the upper respiratory tract. The immune system is going to become sensitized and it's going to form antibodies, protective antibodies against them. But we need to be very careful with the live attenuated vaccines. They cannot be given to immunocompromised patients. So the preventive measures is for the virus is the vaccine, and the control, infection control measures such as washing hands, keeping away from, if you're infected with influenza, do not go to work so that you do not infect others. The seasonal influenza vaccine is given to at-risk patients, also to the healthcare workers. The at-risk group include 65 years of age or more, pregnant women, those who have long-term health conditions, a healthcare worker, or living in a nursing home as well. History of flu vaccine development. The influenza virus was first known and isolated in 1933. Then in the 1940, inactivated flu vaccine developed. 1960, first flu vaccine licensed in Europe. 78, first trivalent vaccine. 2012, the first quadrivalent vaccine was licensed in the US. And what we mean by trivalent and quadrivalent is trivalent have 2 type A and 1 type B. The quadrivalent have 2 type A and 2 type B strains of the influenza virus included in the vaccine. So for the influenza vaccine for the year 2019-2020, which is this year in the Northern Hemisphere, so there is a recommendation by the WHO for the Northern Hemisphere and the Southern Hemisphere, because during January and February it is winter in the Southern Hemisphere, while it's summer in the Southern Hemisphere. So for this year vaccine, we have 2 type A and 2 type B. The type A, the first type A, is the H1N1 PDM09-like virus, which is the H1N1 virus, which caused a pandemic in the year 2009, but it was further modified in the year 2018, and it included the Brisbane strain. Also the H3N2 virus, and it was also updated in 2017 from the Kansas strain. The two type B, we have the Colorado, which was updated 2017, the B Victoria 87 lineage, and also we have the Phuket 2013 Yamagata lineage. Why do we have to take the vaccine annually? Because, as we said, there is the antigenic drift and the antigenic shift. It is mostly because of the antigenic drift, which introduces point mutations over the years. Does flu vaccine give you the flu? Especially when we're talking about the shot vaccine or the killed virus vaccine, it's very unlikely that we're going to get flu because of the vaccine, because it's killed or inactivated. It was tested to ensure safety. The vaccine usually starts to work within 2 weeks, so if you get straight away infection or flu-like symptoms, then most probably you've been infected with an influenza virus or other viruses like rhino or coronavirus, which are unrelated to the vaccine that you have taken. Are there any side effects? Yes, there are side effects, especially soreness at the injection site, local reaction, fever, and there are other rare symptoms which you might get as a result of vaccination. Contraindication, since the influenza vaccine is made in eggs, the egg allergy is a contraindication to take the vaccine. Also, if the child or the adult have a febrile illness, then he should not take the vaccine until recovery. Truths and myths about the vaccine. So if you take the vaccine, is it correct that you're not going to have flu during this winter season? That's not completely correct, because influenza is one of the viruses that might cause the common cold or flu. So you might become infected by other viruses such as the respiratory syncytial virus, rhinovirus, coronavirus, which cause common cold or flu-like symptoms. Also, the vaccines which we take in our region are designed either in Europe or the USA, so they might have strains which are a little bit different than what we have in our region, though the recommendations, as we said, come from the WHO for the most pathogenic strains within the past year, but still this is a possibility. The vaccine does not prevent, as we said, other viruses, and it is very rare association with Guillain-Barré as a result